All right. Well, welcome back to the afternoon portion of our meeting today. I'll turn it back over to Dr. Balms to introduce the next speaker.
Thank you, Dave. So our next speaker is Dr. Krishnan, Anand Krishnan. Take it away.
Yeah. We have to put it in a slideshow mode. Yeah, thanks. Good. Thank you. Good afternoon. Continuing along. You hear me okay? Okay.
Yes.
It says you're muted. All right. Thank you. In this presentation, I'll focus on toxicity evaluation, risk characterization, and present the conclusions of the draft report. This study examined the non-cancer hazards and cancer risks as the health outcome, as you see in the first column, from exposure to chemicals from crumb rubber infill via multiple routes, as shown in the second column, inhalation, dermal, and ingestion, on the synthetic turf fields for 4 receptor categories: athletes, coaches, referees, and spectators, and appropriate age groups in each one of those categories. So specifically, the toxicity evaluation or the health outcome focused on acute inhalation exposure to chemicals. That's the first line combining the first 2 columns. And 1-day inhalation, oral or dermal exposure to DARTs, or the developmental reproductive toxicants, or chronic inhalation exposure to sensory irritants, then chronic inhalation, dermal, or ingestion exposure to general toxicants. We refer to as general toxicants those that cause chronic effects other than DART or sensory irritation, where the key or critical effect is other than sensory irritation and developmental reproductive toxicity. And then cancer outcome, where we calculate the lifetime risk from exposure to carcinogens by inhalation, dermal, and ingestion routes. In applying these on-field or for off-field exposures, the only difference is that the turf materials are only present on-field. Obviously, that's the only difference when it comes to the calculations on-field or off-field. In terms of the toxicity evaluation of these chemicals or the dose response assessment of these chemicals requires the knowledge of toxicity criteria. The toxicity criteria are basically a numerical value that quantitatively characterizes the relationship between the exposure and the outcome, such that either a reference exposure level is developed for non-cancer endpoints or cancer slope factors are developed for carcinogens. In terms of developing toxicity criteria, we had 5 complementary approaches. Initially, toxicity criteria developed by OEHHA or other governmental agencies were used. Then extrapolation using toxic equivalency factors was conducted, particularly using benzoypyrene for the pHs, and then adopting toxicity criteria from structurally similar chemicals, and then the conduct of route-to-route extrapolation of toxicity criteria. When a value is available for oral route, converting it to an inhalation route, and vice versa, is particularly for systemically acting chemicals. And finally, development of de novo toxicity criteria for chemicals based on toxicological studies from the literature. For chemicals with the established toxicity criteria, the most health protective value based on the most sensitive endpoint was used. And for chemicals without such established okay, that's good. Because my picture keeps coming in the middle of the slide, so it's hard to read. So I put all of us that way. For chemicals without established non-cancer toxicity criteria, as I alluded to earlier, new toxicity criteria were developed either de novo or based on route-level extrapolation or based on structural similarity. And for those without any toxicity criteria or toxicity data, those weren't included in risk characterization. In terms of the data availability for acute toxicity, there were 11 chemicals with tox criteria from OEHHA or US EPA for inhalation route. So that was for the acute inhalation toxicity. And for those without tox criteria for the acute exposures, comparisons were made with the subchronic health guidance values. Even though subchronic is a longer duration with lower health guidance values, those were used in this project. Then regarding DART, 6 chemicals had tox criteria from OEHHA or EPA. 2 were developed in this study and 12 were based on structural analogs. And for sensor irritation, there were 3 chemicals, as we will see momentarily, and all of them were from OEHHA. And in terms of the chronic toxicity, for the inhalation route, 41 values were available from OEHHA, EPA, and ATSDR. 52 were based on analog values, structural analogs, and 37 were developed based on route-to-route extrapolation. In terms of the oral and dermal route, the toxicity criteria, 18 of them were available from OEHHA and EPA, and 36 were based on structural analogy. And 4 relatively non-toxic chemicals were excluded from these calculations. The limonene, pinene, and cadene were those. And in terms of the cancer slope factor, out of the 23 identified carcinogens in the study, 16 of them had chemical-specific cancer slope factor. 5 of them had established potency equivalency factor or toxic equivalency factor. Those are the PHs, polycyclic aromatic hydrocarbons. And for 2 of them, we had derived specific values in this study. And of the 23 carcinogens, 13 were identified in a single route with a chemical-specific cancer slope factor, whereas 10 of them were assessed for multiple routes of exposures, inhalation, dermal, and ingestion. So in terms of risk characterization, combining the exposure assessment and toxicity criteria, we evaluated the acute and chronic non-cancer hazards as well as the lifetime excess cancer risks for each category. That is athletes, coaches, referees, and spectators for a total of 33 groups. Based on individual field data on chemical concentrations as well as the average across fields, as we had indicated. And acute and chronic exposure scenarios for both on-field and off-field were considered in computing these, the cancer risks and non-cancer hazards. For non-cancer hazards, initially a hazard quotient for each chemical was calculated. So hazard quotient is basically the ratio of the exposure metric to the toxicity criterion or a reference value. So the exposure metric is either an exposure concentration or a dose that's calculated. For inhalation exposures, it's an airborne concentration, whereas for dermal and ingestion exposures, it's an average daily dose. And the toxicity criterion is a chemical-specific numerical value that reflects the potency of the chemical for the specific non-cancer effect on the route of exposure. An example would be the REL, or the reference exposure levels developed by OEHHA. So these are concentrations at or below which no adverse health effects Yeah, thanks for bringing that up. Yeah. Now, for cancer risk, it was calculated using the general equation, lifetime average daily dose times the cancer slope factor, CSF, LADD times the CSF for the route of exposure here. The cancer slope factor, or CSF, is the 95th percentile upper confidence limit on the slope of the dose response curve, which is based on continuous lifetime exposure of to a substance. The risk calculations are conducted for multiple chemicals via multiple routes for all age groups. And 1 in a million, or one excess cancer in a population of 1 million people over a lifetime is considered a negligible risk or de minimis risk level. So that's the benchmark that I would be referring to as we go along. So now let's start with some of the results of risk characterization. First, for acute toxicity, using the maximum 1 hour concentration of a chemical detected at any time in any of the fields, the acute hazard quotient for the inhalation route was well below the benchmark of 1, both for on-field and off-field exposures. So there was a single field-related chemical and 10 non-field-related chemical. And this table shows that the on-field acute hazard index was well below 1 for the field-related chemicals, and also was below 1 for the non-field-related chemicals. And same scenario for the off-field. The styrene was the only field-related chemical with toxicity criteria here, whereas acetaldehyde, benzene, 2-butanone, 2-butoxyethanol, formaldehyde, phenol, tetrachloroethylene, toluene, and xylenes were the non-field-related chemicals that were included in this calculation. You had already seen these during this morning's presentation. So those were the chemicals that had sources other than crumb rubber fill, infill, or the synthetic turf field as the source. For the field-related chemicals, without toxicity criteria for acute exposures, we have made comparisons of maximal air concentrations with available subchronic health guidance values from other sources. So there are 3 of them available from US EPA's PPR-TV database and ATSDR's HIMRL. And in all those cases, those concentrations were much lower than the subchronic health guidance values as well. And similarly, for one-day dermal and ingestion exposures, there were no one-day toxicity criteria available, but there were no exceedances based on comparisons with the subchronic health guidance values for the dermal or oral route as well. Now on to developmental and reproductive toxicants. Here, on average, the hazard index was less than 1, ranging from 0.01 to 0.58 for all the receptor groups and age groups. That was based on the 24 field-related chemicals. So it's adding the hazard quotient for all of the chemicals via all of the routes, yielding a hazard index which was well below 1 on average. Looking at the individual values, the maximal value we could find were there were cases where it exceeded 1. That would be for athletes of 11 to 17 years old, where it ranged from 1.2 to 1.8. The chemical driver in this case was benzoylpyrene. Benzoylpyrene was one for which the toxicity criteria was calculated using an uncertainty factor of 3,000. This means the reference guidance value for humans is 3,000 times less than the lowest concentration at which adverse health effects were observed in animals, just to put it in perspective in terms of the data gaps for benzoylpyrene. And it's also relevant to note that the parameters and assumptions used for the exposure assessment, well, I'll come to that in a moment. So here, this picture captures the maximal hazard index. You know, the hazard index was calculated for the 24 chemicals for each one of the fields. I'm picking out the maximal numbers. One can see that it ranged from 1.2 to 1.8 in athletes of 16 to 30 years old, whereas in all other cases, it was below 1. All the average values were within 1, the benchmark of 1, whereas the maximum individual value that we had seen were in the range of that 1.2 to 1.8 in those 3 cases. So these hazard indices, once again, were calculated based on the 24 chemicals, accounting for inhalation exposure during about 3 hours during each game and practice, ingestion of about 300 milligrams crumb rubber per event, and dermal exposure based on skin load of about 180 milligram crumb rubber per event. And the odds of all of these occurring in these age groups were actually low, thereby indicating a low probability of observing a hazard index of 1.2 to 1.8, which is well within the uncertainty factor of 3,000 used for benzoypyrene, which is a driver in this case. Now on to chronic exposure to sensory irritants. Here, the hazard indices were well below 1 based on either the field-related chemical, which was styrene, and the 2 non-field-related sensory toxicants, which were formaldehyde and acetaldehyde. So each individual field hazard was assessed using the field's average concentration for this. So each field, the sensory irritation hazard indices were calculated based on values from each field. So these were below 0.01 for the on-field exposures for all exposure groups. And the off-field numbers were always below 0.01 and not shown on this table. So overall, only the field-related chemical styrene evaluated as a sensory irritant did not present a hazard on-field or off-field. However, you do see the contributions from the non-field related chemicals in the second column, as the maximum numbers did exceed 1 in case of formaldehyde and acetaldehyde as the non-field related contributors. Now on to the non-cancer hazards, chronic effects. The average across fields was below 1. The hazard index was below 1, ranging from 0.03 to 0.5 for all receptors. So this was based on 99 field-related chemicals and 21 non-field-related chemicals. Now to the second scenario of looking into the individual field values, the maximal hazard index was below 1 for all receptors except in 2 cases, or in 31 groups except for 2 cases. One is the athletes of 16 to 30-year-old, where the hazard index was equal to 1. And the second was on-field spectators 0 to 2 years old, where the hazard index was 1.2. So the on-field spectators are children going off of the spectator stands onto the play field, sitting, playing, and eating in the field. Those are the on-field infant spectators that are being referred to here, where there is a small exceedance compared to a benchmark of 1. And in this case, the driver was lead, and ingestion route was the main contributor as well. So, so pictorially, I'm just capturing those chronic hazard indices for the field-related general chemicals. In this case, you see the values for athletes and then coaches, referees, And finally, the on-field spectators, where you see the infant group all the way in the top. That's the blue circle that you see just above the dotted line. And that's the one that I'm referring to. So these are the maximum hazard indices calculated. And this value for the on-field infant spectators, as I mentioned, is driven by ingestion and by lead, basically. And in all other cases, these are well below the reference value of 1. And also very often you see all of them congested together below. That's why you don't see all of the colors in there. So they're all kind of together in there at the bottom, on the bottom and at the lower levels. So this pictorial shows that the ingestion contribution is the main driver of the hazard index in the on-field spectators or the infants, where you see the distribution of hazard index that goes from below 0.2 to 0.4 to 0.6 to 0.8 to 1 and about 1. That's the last case where I referred to with a circle in the previous picture. And in all cases, it's the ingestion that's the driver. Whereas in the athletes of 16 to 30 years, it's mainly the inhalation that contributed, which was a driver of the hazard index. Finally, the cancer risk. Here, the mean cancer risk for combined exposure to field and non-field related carcinogens was greater than 1 in a million for all receptors. And it was primarily driven by the non-field related carcinogens. The non-field related carcinogens accounted for more than 90% of the cancer values. Okay, that's the mean. And the mean cancer risk levels associated with field-related chemicals in all the receptor groups, athletes, coaches, referees, and spectators, were below 1 in a million, except for one group, the on-field infant spectators, for which it was slightly above the benchmark, which was at a 1.1 in a million. So once again, the on-field spectators are the ones who go from the bleachers onto the field, sitting and playing and consuming. And based on the individual field cancer risk levels, the maximum, when you look at the individual field cancer risk levels, the maximal value exceeded was greater than 1 in a million in two groups. One, the on-field infant spectators, where the range was 0.3 to 2.7 in a million. So the 1 in a million is encompassed in there, or the slight exceedance is encompassed in there. The same with the athlete groups as well, as I'll show in the next 2 slides. So here you see the range of the values, the cancer risk levels in each one of the age groups of the on-field spectators and off-field spectators, based on multi-route considerations and multi-chemical considerations. And I draw your attention to the first bar graph that exceeds the dotted line. So here it goes from it goes from 0.3 to 2.7, right? That's the, so those are the, that's the range of the values calculated for the on-field spectators. One of the considerations is the assumptions and parameters that go into the exposure assessment in characterizing the risk for the on-field spectators, the infants that get on the field. They're exposed to about 3 hours per event, 161 events per year for the infants. And these are numbers from the supplementary materials. I'm just repeating them. And oral exposure to 153 milligrams of crumb rubber per event, per game that they go to, 153 milligrams. during those 161 events. And dermal exposure or a skin load of about 50 milligrams of crumb rubber per event during the 161 events on the children, on the infants that get onto the field. So these, considering all of these, worst case scenarios and parameters used, we conclude that that these do not raise to significant level of concern. And also, there's the additional application of an age sensitivity factor of 10 to calculate the cancer risk for infants of 0 to 2-year-old. Calculations as Jocelyn had shown this morning. So considering that, we would say consider that this risk level is low, but of possible concern, particularly because of the hand-to-mouth activity and the ingestion of crumb rubber infill in the turf fields by the infants. Similarly, these are the ones for the athletes. And I draw your attention to the 2 bars where they're slightly above the benchmark of 1. The whole range goes from well below 1 to a little above 1. So having presented these numbers for the cancer and non-cancer risks, let me move on to address the considerations of variability, uncertainty, and limitations of the study before concluding. In terms of the variability, it was addressed to the extent considering the various subgroups, the 33 subgroups, 7 athletes, 4 for coaches, 4 referees, 9 on-field spectators, and 9 off-field spectators. Additional aspects that deserve mention are the sample heterogeneity. Given the crumb rubber infill is produced from a variety of sources, in terms of automobile waste tires, different tire types, models, brands, production years, age in traffic, and so forth. But OEHHA considered this heterogeneity in the analysis of crumb rubber variation within samples and within the fields in their analysis. Then for time, activity, and exposure parameters, as Dr. Claude mentioned this morning, we conducted a California-specific time activity survey to derive athlete-specific physical parameters and also soccer-specific exposure parameters to better characterize exposures and better characterize the variability there. And in terms of the athlete player position, even though we did not consider the variability among the various athlete positions, given the concern for the high exposure of chemicals for goalies due to frequent diving activity and potential ingestion of crumb rubber, the study used the goalie-specific scenario to compute the risk values for all athletes and athlete exposure scenarios. And in terms of uncertainty, any risk characterization should recognize the sources and impact of uncertainty. In this regard, I would bring about 3 aspects here. One, on the subject of chemical characterization and source designations, a critical concept and aspect of designating the chemicals as being field-related or non-field related. You saw the methodologies that were used to characterize them, but in this study, however, we conducted and presented calculations for both field-related and non-field related. That's a way to address that concern for uncertainty. And then in terms of exposure assessment, the parameters for coaches, referees, and spectators were based on the time activity survey collected in athletes. And we used the highest mean values from athletes for all the other groups to be health protected. And this task survey did not provide any information about the amount of crumb rubber ingested during the course of soccer activities. So OEHHA used the literature data to estimate the direct ingestion amount, and it is likely to be a conservative overestimate in the exposure and risk assessments. And on the topic of dose response assessment, I think we have already touched upon that for non-carcinogens, for chemicals without established values, for which we developed new values, applying the appropriate factors. And for the DARTs, considered a single exposure event as being the as being sufficient to cause developmental and reproductive health outcomes. So we did not use an overall average or anything, but we considered just a single day or single event concentrations there. And also the use of the toxic equivalency factor or potency equivalency factor of BAP or benzopyrene for other pHs is certainly a source of uncertainty to be kept in mind in this context. That's what was used to derive the toxicity criteria for benzanthracene, benzofluorantine, chrysene, indenopyrene, and cyclopentopyrene. In terms of the study boundaries and limitations, I just want to emphasize that we evaluated the crumb rubber infill, but not the backing materials or the brass blade components. And no analysis for metals and fine particulate matter from the air was conducted due to logistics and logical constraints. However, we measured the bioaccessible concentrations of metals and crumb rubber for evaluating ingestion exposure, as you saw in the morning's presentation. And finally, the study conducted assessments for each receptor category and not for various scenarios of combined receptor roles, which can be done given that, like a person acting in multiple roles during a single event or on different roles during a year or more than a year and so forth. But a time-adjusted hazard index or a combination of cancer risks can be calculated based on what we have presented. But given the sufficient number of hours of exposure hours used per year in these calculations in any given role, and given essentially that all the risk values were below or above the acceptable benchmarks, the likelihood of significant health risks arising from combined receptor scenarios is considered to be low, and we indicate that in the report. So to conclude, overall, based on the available data, the methods used, and the limits of described in this report, overall, the study found no significant health risks in terms of acute toxicity, developmental and reproductive toxicity, sensory irritation, general chronic toxicity, and cancer risk to players, coaches, referees, and spectators, from on-field or off-field exposures to field-related chemicals in crumb rubber infill from synthetic rubber synthetic turf fields. And based on the maximal values from the individual field data, there were a few instances associated with turf field-related chemicals that are of low odds of actually occurring, that one would consider as of low probability and of low concern. And that would be in 3 cases: DART for athletes aged 11 to 70, chronic toxicity in the on-field infant spectators, and the excess cancer risk in on-field infant spectators and athletes of 60 to 30 years. And much of these calculations for the on-field infant spectators would indicate that the necessity for the emphasis to reduce the hand-to-mouth activity and limiting the time on the turf field for the infant spectators who get off the spectator stand and play on the turf fields. I would stop at that and address any questions or clarifications, either to me or to Chelsea.
Thank you, Dr. Krishnan. So the floor is open for the panel. The dais is open for the panel to comment. Andy, do you want to?
This is Sandy Eckel. I have a sort of clarification question about the elevated DART for athletes age 11 to 70. I think it was on page on slide 15. I was just trying to understand the heterogeneity on slide 15, the hazard index estimates for athletes. And I noticed that you know, I at least see 3 dots that are above the 1 and 1 dot that's very close to 0. And I was trying to understand what was the driver of that heterogeneity in those estimates there. Was it like different breathing rates, or because it seems like it's by age, these differences, and I was trying to understand why there was such a difference there.
These are the, do you want to start or you want me to start?
So I can start. So a lot of those groups that are down, is it on?
Not audible.
Can you hear me better? Oh, okay, okay. So a lot of those groups that are down there toward right on the x-axis, so they look like they're 0, but they're those are the values that are like the less than 0.01. And for most of those groups are the younger age groups. So their time on the field is a lot less than those older age groups, you know, and they may not have as many practices. They might have 1 practice per week, whereas some of the other groups might have 2 or 3, you know, practices and games. So a lot of that is due to like differences in exposure frequency. You do get some of those breathing rates in there because the younger kids aren't going to have as high breathing rates and have, you know, such high exertion levels as some of the higher, you know, more competitive athletes. So a lot of what's driving that is those types of differences and kind of just physiological differences in breathing rate and then duration and exposure frequencies.
Yeah, thank you. So these are maximal values for any of the age groups. So if you pick the one on the top, the 1.8, that's for the 16 to 30 years. So the average for that across the 35 fields was 0.6. So from that distribution, we just picked only the maximal value to show here in each one of those cases, just to show. But all of the averages for all of the age groups were well below the reference hazard index of 1.
Great, thank you very much. And then I had one other sort of, I guess, more big picture comment. You know, my expertise is more in epidemiology studies, and I noticed that, you know, it seems like these risk assessments are all sort of, you know, chemical by chemical. And it's very popular in epidemiological studies these days of multiple exposures to look at like interactions between different exposures. And it seems like this might not be possible in this kind of study, but it might be worth it to mention the limitations that you know, the elements were considered one by one rather than like potential joint effects of multiple chemical exposures, if I understand correctly.
And one way of, we'll certainly take that into account and mention that. One way the study has addressed that is by adding the hazard or the risk associated with each one of the chemicals. So it's the additivity that's used in this particular case. Right? So that's the hazard index. Yeah.
While we're on this slide 15, I actually like the way that age strata are shown here. But in like conclusions, when you say DART for athletes age 11 to 70, it's the 70. Yeah, I'm 75, so I appreciate you worried about developmental and reproductive toxicity for old people, but it doesn't, I don't know, for public, it just seems like too wide of a range in terms of summarizing things. Again, I don't have any problem the way it's broken down on slide 15 because you have each age group, but it just sounds weird to have DART for athletes aged 11 to 70. I know people are still playing soccer at 70, but I don't think there's too much concern about developmental reproductive toxicity at that level, at that age. Just it doesn't quite meet the laugh test, you know, to me.
And I had a quick question about this slide too, because I wasn't clear. I thought you didn't calculate the DART for 6 to 11, but you did calculate the DART for 6 to 11 and it was basically 0. Isn't that one that's on the line, the 6 to 11? What's the value of? the 6 to 11 years. Isn't that that dot that's basically athletes at 0? That brown dot at 0? Eleven would be.
So the 6 to 11 for field related darts was less, it's less than 0.01. So it was very low. So it's the 11 to 16 through 50 to 70 that encompass those 3 dots. And there's a little bit of overlap between them for those 5 age groups.
And so the 6 to 11-year-olds had basically like 100 times less exposure.
Very low, yeah. And also too, one thing to keep in mind that because these are individual field calculations, so there's 35 fields, so not every dart was tested and detected on, well, not tested, well, it was not detected on each field. So some fields may have less detection than others. So that also will take into account in the average. You know, you might have one field that's only got 3 versus one that's got all of them. So some of that difference in you're seeing in the levels of the hazard might be due kind of to that too. Just some fields just having fewer chemicals detected on it as well.
Yeah, it's just surprising that the exposure is 100 times greater for 11 to 16-year-olds than 6 to 11-year-olds. Just big difference.
Did you have?
I was just surprised by that. I did have one other question, I guess,
Yeah.
if you want me to keep going while I'm here. Or do you want to go and then I can ask my other question?
No, you have the floor. Go ahead.
Okay. I noticed on the 0 to 2-year-olds, you had lead exposure rates, but I know on, again, sort of from epidemiology and whatnot, we're really saying no level of lead exposure is safe. And so I felt like, yeah, you guys probably are taking a published value for the levels of lead exposure that were considered safe, but I feel like it would be important to note that at this point, we kind of consider no exposure to lead as being acceptable. I mean, I do agree that, you know, you've got, I think that 153 grams of field ingested is a lot. Again, it'd be probably good to convert that into some sort of measurement we can understand. But even so, I feel like you needed to say a little bit more about any lead exposure being problematic. It sounds like John might concur with that thought.
Well, yes, I definitely agree that no level of lead exposure is currently advised for child development, cognitive development. You may, Dr. Kyle.
I had the same, I support your comment about if you're adding lead to children's environment, that's a health concern, irregardless of these numbers. So, but I was wondering what you use for the hazard index for lead, because we don't have a hazard index for lead number because there's no safe level of exposure. So I was just, you know, it talks here as if a hazard index calculation was used, and I was just wondering how you did that, because I don't think OEHHA even has one, do they? And if this is a lookup, you can answer that later. I don't want to draw the meeting to a close for,
Yeah.
you know,
so
a fine.
look it
This
up
is
and
a small question. but
Yeah, so it's
you
in the
understand my
report, yeah.
question. Okay,
Mhm.
thank you.
Yes.
While they're working on that, do you have any other comments, Dr. Kyle? Yeah, you may.
And this is maybe more a matter of writing than the science, but the distinction between the so-called field-related chemicals and the so-called non-field related chemicals is soft in this under these methods. because as the report says, this is what the report says somewhere else, that we're not really sure whether what is measured on field and off field are real differences between what comes from the crumb rubber and what doesn't, because of the proximity of the areas, for one reason. The space between what was measured on field and off field wasn't necessarily that far away or free of wind interference. And also, there is another reason, I'm blanking on it right now. But, and so I guess I feel like this makes too much of that distinction. You know, the way that some of this is done, it really makes it look like we know that these are the ones that are, quote, on field, which means from the crumb rubber. And though these other ones, which are off field, are therefore not from the crumb rubber. And we're not as sure about that as this sounds. And I remember the second reason now. The second reason was because the crumb rubber also may have blown around. It's not necessarily strictly limited to the field or any specific proximity. It gets tracked in and out. So that could be another reason. So I'm not saying we shouldn't do this, but I feel like that softness of that distinction doesn't get drawn into the discussion about, I don't know if that's exactly uncertainty. I mean, it's a limitation, I guess, or something like that. I'm not sure what category to put that in, but I feel like that was missing from this discussion. And it's really quite important.
Yeah.
And also probably unknowable without spending a lot more money, which is kind of part of well, what do we learn from this? You know, what kind of studies can we do to figure out actually in the environment to make these small differentiation between what's actually on a field? And, you know, in my mind, then does that mean that when is this kind of research valuable, or when should we look at what the ingredients are and make decisions and findings based on that? That's a policy question, not a science question. But I'm thinking about what did we learn from this? And one thing we learn is it's hard to be clear in the environment about what's ambient and what comes from where in a dispositive way. And I can still commend your efforts. We learned a lot from this. And so I'm not being critical of doing it, but just that maybe the distinction is too strong. And as we think about what we can learn and where in the sort of chain of use, et cetera, it's worthwhile to do studies and how we can make decisions. You know, it's on my mind a little bit. Is this when is this helpful? It's related to the question that someone raised about, well, are these facts still true? You know, when you have something that you know is an unmanaged mix that's uncharacterized, it may change in the form of the waste rubber in ways that no one will flag for you. So how long are findings like this good for, and what are the implications for that? And should we spend more time measuring upstream to see whether the incoming stream is changing? So that's those are some thoughts on my mind. And
Could I butt in for a second?
yes, please, because I need to look up my next point.
Because to be fair, and I don't disagree with you that maybe the softness of the field versus non-field exposures could be highlighted, but section 7.5.1 actually does talk about the issue of field versus non-field being difficult to characterize. So it may not have been spelled out as clearly as I think you'd like it to be, and I agree with that, but it is in there.
And I said it was in there.
Oh, okay,
I
I'm
said,
sorry,
I know you have it in here, and that's where I learned about it. You know, I mean, I'm quoting back to them really their own text. That's okay. Well, I maybe was confusing in my presentation. But I think in the way these data are structured, it doesn't reflect that. It makes it sound more like a real.
And I agree with you.
Okay, thank you. So I will yield the mic for now.
I wanted to see if Dr. McCone, who's online, has any
Yeah,
thoughts. There you go.
I had
Your
my
hand
hand
was up. I
raised.
just couldn't see you.
Oh, okay. Yeah, I don't know if the hand raise function really works. Yeah, I just have a couple of points. One's kind of a technical question, I guess. So just to be clear, each of the hazard quotients that were used to aggregate a hazard index, I think you said the toxicity criteria came from either OEHHA, probably a RAL, or typically a RAL, or EPA, right? And the choice was the choice based on which was most restrictive, would lead to the highest hazard quotient? Or were they all OEHHA RALs? I can't hear. I'm not hearing the answer. Sorry, I'm not getting.
Okay. No, I was just
There
practicing.
we go.
what
Now I
to
can
say.
hear you.
Yeah,
I couldn't
okay.
hear a thing when you started answering.
There's a schematic in chapter 4 that's presented as to how the values were chosen. It's the most health protective value
Right.
with the way as being the priority.
Right. So that's what I thought. So it would either be, it wouldn't be preference to RAL, it'd be preference to the most health restrictive, right? Which makes sense. I'm just saying it makes sense. So the question I have though is, it might be useful to look at the date that the toxicity criteria was established. For example, I've done this where we look at OEHHA REL, or we look at EPA reference dose, and sometimes the one that is most restrictive is also the oldest and may even be 20 years old. And so one of the things that, not that it would really change things, but it might be interesting to see if this is the most restrictive value is based on more recent data or older data. And I don't think, it's not that you should change it, but it's interesting to see, in terms of understanding some of the uncertainties and other issues, it would just be useful to have a date associated with the toxicity criteria that was used in the hazard quotient, right? And I don't know if that's possible, but it's kind of useful because for an outsider to look at it, I'm like, oh, well, it was really restrictive, but it was like 1970 study and nobody's updated it. Oh, another comment, while people were talking, I looked up OEHHA's website. There is no REL for lead that I could find, but there is a Prop 65 MADL, maximum allowed daily
Which
limit
one are you referring to?
for lead. So,
Lead?
the
Okay,
whole
it's
thing
in
was
Appendix E8.
there's no safe dose for lead, but Prop 65 actually
Yeah.
has MADL, right?
So for DART, for DART,
Not for dog.
established
I think I don't know well, it's reproductive under
Yeah.
Prop 65, so
development.
that might have been what you were using in the toxicity criteria.
It's our
Yeah.
maximum allowable daily level.
Yeah,
Yeah.
that's the model.
Yeah.
And that's what is indicated on
Maybe,
page E8 of the
Yeah, okay.
appendix.
I mean, we were saying there's no standard, well, there is no REL, and I'm not sure about EPA, but Prop 65 does have a number, just for information. I guess now this is more of a broader comment, and it has to do, and I think in your summary and discussion, I really welcome the fact that it kind of gets into issues of confidence and how safe people are, and maybe, I get a little nervous when somebody says, well, 1 in a million is de minimis and we're all safe. But if it goes above that, I always get a little uncomfortable when somebody says, well, it doesn't meet the standard because it's 2 in a million. And I always ask, well, if somebody made a bet with me and said you have a 1 in a million chance of winning $1 million, how much would you pay? And then they say, oh, what if it goes to 2 or 2.7 in a million? Would you double your bet? And it's like, no, not really, right? It's 2 in a million. In the grand scheme of things, 2.7 in a million is, in the reality of likelihood and things is not that. So I think instead of focusing as much on, oh, the hazard index went slightly above 1, or the risk was a little over 1 in a million, it might be, not to focus so much on that as the fact, what I see in this is a study that says, yes, there's health issues, but we have high confidence based on everything we did, looking at exposures, looking at toxicity factors. We're down in numbers that any reasonable person would be comfortable with if you trust the toxicity and the exposure assessment. And again, it's just how we discuss our confidence or communicate the fact that the study really points to the fact that the community is quite safe. There's no reason to run out and put a ban on all soccer playing on synthetic turf. And again, that's just a little bit about crafting the language for communities. So I'm not sure quite how to do that, and others may have an idea, but I do get a little nervous when somebody says, well, if 1 in a million is acceptable, 2 in a million is like over the limit, so it's not good. All right, anyway, that's kind of the end of my comments.
Thank you. Thank you, Dr. McCone.
Oh, could I chip in real quick?
Go ahead, Jocelyn.
So I just want to address the toxicity criteria. So we did choose values that were the most health protective, but we also did put more weight on more recent assessments. So in the case where we did have, some of those chemicals that had, criteria from, the 80s, if there was a more recent assessment, if the value maybe wasn't as low, we did still look at all the data and, and quite possibly choose, maybe a value that was higher because it's based on more, more recent data of higher quality. So we did take that into account. And in the appendix, I believe it's Appendix E, all of the studies and all of the years for all the criteria that are used are presented. So that data should be in the appendix.
Oh, that's wonderful.
And the workflow is captured in figure 4.1 in the main report. That shows not only the most health protective, but also the most recent value was sought for and used. Thank you.
Thank you for that clarification, Jocelyn. Okay, so Ed, do you have any comments?
Yes, thank you. I'm still struggling a little bit with, I guess it's more in the sense of interpretation and how this is going to be understood by the public. So I'm looking at, I guess, slide 15, the 1-day hazard index, and that plot that showed the athletes over varying range, and then the conclusion, slide 27, I guess, that sort of said the DART for athletes age 11 to 70. So one comment just as a side issue for those of us who are color challenged and looking at a chart, would it help me to somehow identify what those 4 dots are under athletes to know who we're talking about? So could you just tell me once again, so I can make sure that the comment I'm about to make makes sense? So the top one
is 16 to 30 years. The gray one is 50 to 70, and the third one down.
What is the gray one?
So a little bit below 1.4, and then the third one at 1.2 is 40 to 50.
Third one is 40 to 50.
And the one on the bottom
And the one on the bottom?
is 6 to 11.
6 to 11. Okay.
Actually, there's a table in page 6.7 or chapter 6, page 767. That's the table that has these numbers.
Okay.
And
No,
we only try to pull out just the maximum numbers to show in this.
So I appreciate that the report is much more detailed. The numbers are there. But if you're going to use a chart like this to sort of summarize it so people can look at it, I think want to be sure that you get the right message across that you plan to apply. So then the question again is, not to dredge it up again, this 6 to 11 being almost at 0 on the sheet here, which was a little surprising given that, children, sort of ages 7 to 11 are sort of a large, if not substantial component of the soccer population, the kids soccer population. They get per kilogram mass, they get the pretty high ventilation rates when they're running around and they're close to the field. So they're potentially in the right exposure range. And based on what your previous comment was in terms of I guess even a cancer risk, you said it was from 10 to 1. You assigned some numbers with the highest number being in the lowest ages. So it seems like they would be in the higher category. So it seems like I guess my expectation would have been they were all in pushing in the direction that they would have been sort of highest in range, and they came out sort of just barely being measurable in the chart. And so that I don't dispute the data, the actual data. If that's what it says, that's what it says. And it's just a question of the interpretation, how you explain that, because it seems like it's I wouldn't say inconsistent, but it seems like it's counterintuitive to what all the built-in considerations were leading up to that calculation. So it seems like it would be helpful to have some sort of sentence or two that explains why even children who we are potentially most concerned about being exposed on these fields in this calculation turns out to be sort of those we need to be concerned least about.
And Dr. Bennett just pointed out, I didn't notice this before, the 11 to 16 is not even showing up.
Well, and what's also curious is when you read the table in the text, they don't list a value for 6 to 10. They start at 11 to 16 in the table. Now I've put my thing back. I don't remember what table it was. So it didn't even show that they calculated a 6 to 10.
But on slide 15, there's no,
Probably under another value, right?
it must be under the athletes, it must be under 6 to 11.
So in the report, so in the tables, for the individual exposure routes, if the value was below 0.1, it wasn't put in the table. So those are the values only that are above 0.1. And so for the field-related DARTs too, inhalation was the primary driver of the pathway, and those were very low for those age groups. So that's why they're not in the inhalation table, but they are in the tables for the oral exposures.
But their chronic inhalation, if you look at table 610, the 6 to 11-year-olds have very similar values to all of the other age groups for inhalation.
Yeah, and the other thing is, as Dr. Avol just said, or Mr. Avol just said, the ventilation rates of young kids relative to their body mass is high.
Yeah, and so some uncertainty in that aspect. So in the survey we had a very small number of participants aged 2 to 6. So for that age group, I think we had 3 6-year-olds who filled out information. So we did ask them, information about exertion levels. And so their reported exertion levels were lower than like the athletes who, they do say, they're running at high intensity, for most of the practice. Whereas, the borrowed 6-year-old data, they didn't report having
and then throwing in that the kid's also probably one of the referees to really get at, kind of modeling a kid that soccer is their youth sport and they do it all, you'd have a risk value. If you added those up, that is slightly over 1 times 10 to the minus 6. It'd probably be like 5 or 6. But, just to do that and show, look, even if we're really conservative and have all the, you were dragged to the soccer field as an infant to watch your older sibling, and then you played, and then you kept playing, and then you were a referee. And you pointed out you can add these things up, but you just might want to do a couple scenarios and say, here's what it is. It's still going to be relatively low in the grand scheme of things, but then it just feels like you've taken this extra step to being conservative on the exposure side, and it's still showing that the risks are really, they're above de minimis, but they're still not that high.
Ed?
So I have just a larger question. So this morning we were the beneficiaries of an excellent report on the characterization. This afternoon on one of the toxicity and the risk characterization parts. And so now I'm not sure if there's going to be, I don't think there's going to be a third presentation on sort of the synthesis of what the whole total picture is in the report. So I guess I'm asking, so you put it all together and then you think about what we have. So we have this data set from 2015, and in the appendices, you did go back and you said, well, there've been a number of studies since then, and some additional newer studies are cited, and what the implications or the results, reported results of those studies are, and how that fits with your findings, and how that's assimilated. But I don't know that, in that it's, in some ways, it's sort of like the report is sort of a picture in time. And then in the appendices, there's sort of additional updates on where we are. But in the discussion and summary conclusion in the main body of the report, it seems like it would be useful for the public, for the reader, for people to be able to say, well, don't just think about this as this is something we did in the past. We've looked at what we did, which was exhaustively detailed. We've looked at what's been done since then and to see if there have been any meaningful changes in it. And here's where we sit now, which I think helps to frame the study in a more contextually relevant and important, consideration than saying, well, oh, this was done 10 years ago. We better go look back and see where we are now.
Any other thoughts from the panel? Dr. Kyle?
On the issue of the chemicals that fell out because of lacks of tox values, like the issue I raised in the first session about let's identify where things fell out and what. Building on your comment, that I think it would be good to identify that and just where it fell out and what. And I agree with all the comments that everyone else has made here too. And I guess the last thing I wanted to say is that, I agree our hair doesn't need to be on fire about this issue. It's not an emergency. I wouldn't evacuate playgrounds and et cetera. But if I were advising my friend on the school board about this, I would say, I would try not to use this stuff because it has known toxic chemicals. It's lead. We don't really know everything about it, and you don't necessarily have to. The only context for this is not people coming in and banning it. It's also an information thing about, are we sure it's safe? And I would say, I agree it's not a huge problem or a crisis, but am I sure it's safe? No. So, I think there's a range of questions people ask, and there might be some way to acknowledge that. And maybe there isn't, because it's OEHHA and you're the government and, you're speaking in kind of a government way, and someone might sue you, but I do think that the standard you're setting here in a way is too high, and that a lot of people they want to avoid things that might be hazardous. You know, they want to make sure their kids are using and have safe food and products and stuff. And so if you look at this, and maybe no one wants to answer that, but would you say you're sure it's safe? I would say, you know, I would probably pick something else if I could, speaking solely for myself, but based with having reviewed this. So thank you.
Dr. McCone, any other thoughts?
No, I mean, I think, I don't think a government report can really say what Dr. Kyle did, but I think that's kind of the reality of it is, you know, this is not something, you know, after years of study, we don't see a smoking gun or we don't see anything where, you know, it's time to call out or for the state to take a regulatory action or ban it. But it is, I mean, there's this interesting question of when people say, well, what would you do? And I'm kind of with Dr. Kyle, it's like, well, if you could avoid it, I mean, who knows? I wouldn't, if somebody said, are we at risk? I'd say, no, I don't think you are. But if you asked me, I would look through the data and think about it. And there's a lot of things that are that way, but I don't think the state can write that in a report, but we can say that.
And I'm glad my kid mostly played on grass pitches. Dr. Eckel, any other comments? Well, I guess I would make one kind of comment and maybe let our OEHHA scientists respond. You know, this report took 10 years. I think it's really an excellent report, as we've all said. But I realized there was a pandemic in there. And also change in leadership at the agency and such. And it was a complicated study design with lots of moving parts. But it really did take a long time. And now we're saying, well, is this still relevant, this 2015 snapshot today? So, you know, I'm not being critical of any individual here, but sort of institutionally and, you know, CARB, my agency is part of Cal EPA as well. So it just seems like this took too long. So in the future, when OEHHA has got a big task like this, and there's no question it was big, we probably need to have it better resourced. I guess I'll put it that way. You know, again, not being critical to anybody in the room, because I think you guys have worked hard and have a good report to show for it. I'm just saying, if a CARB report took 10 years, you know, I think there'd be a problem in our agency. So, you know, we finished the morning session early, which I think is a testament to how well it was presented. And so we came back early. I don't think we really need a break, if I can read the room, or at least my colleagues on the dais here.
The court reporter need a break?
Yeah, that was. No court reporter? Oh.
There's a court reporter online. Do we need a break? We're asking if the court reporter needs a break. The court reporter should be online. Okay.
And does the public do we need to have our public comments right at 2:45? Because we don't. Okay, and do we hear from the court reporter?
Donna, is everything okay with the court?
Oh, okay. Thanks, Jocelyn. That sounds like a good plan. Yeah, thank you. Sure. Make good use of the time.
I've been authorized to bring up a detail while we're waiting. And that is, I was wondering if we could look up how you did the PFAS testing on this because of the reason that there aren't standards either for very many PFAS chemicals, And so I'm just curious about
Yeah, and one of the more recent reports did find PFAS.
I think from the grass part.
Yeah, not from
So I'm just
they didn't do the
interested to
grass.
know how you did that, because you said you didn't find any, and I'm wondering, what was tested, what did you test for? That's all, and I don't need to know right now, but thank you. And I guess I would also say, I guess we should have looked at the grass too, in retrospect. Or it's not grass, the plastic
synthetic
stuff.
fibers.
Yes, thank you so much, John.
Blades, yes, blades. Well, we need the court reporter for the public comments, right? Okay, we'll take a 5-minute break while we're waiting to hear from the court reporter.